In Person is brought to Marylanders through grants by Waverly Press Incorporated, the Williams & Wilkins Company, and the members of the Maryland Center for Public Broadcasting.
Hi, I'm Rick Breitenfeld. Surgery. It's a properly serious word, and it's a respected specialty among medical practitioners. Most of us agree that it's good to be sure of the diagnosis before going through surgery. But I'm about to talk with a physician with a national reputation who argues persuasively that there are circumstances under which it is advisable, and sometimes even necessary, to operate without firm diagnosis. This happens in treating victims of the #1 killer of people under 38 years of age, and the #3 killer regardless of age. The killer? Accidents. In person, the director of the Maryland Institute for Emergency Medical Services, Dr. R Adams Cowley. R. Adams Cowley was graduated from the University of Utah before receiving his medical training at the University of Maryland Medical School. He's taught at the University of Michigan Hospital and is currently professor of thoracic and cardiovascular surgery at the University of Maryland School of Medicine. One of his specialties, however, is trauma and the treatment of victims of accidents. Dr. Cowley has published close to 300 scholarly papers and monographs and is a member of 24 professional organizations. He's been a consultant to the National Center for Health Services Research, and his films have won him a National Academy of TV Arts and Sciences Emmy Award for Outstanding Achievement. Dr. Cowley, trauma was not really a big thing in medicine when you first got interested in it in the 1950s. What prompted your interest?
I think trauma has been a problem all of the time, from the time men began to fight. Gladiators or whatever, they injured each other, and trauma is a medical word for injury. And there are more interesting things to many surgeons than trying to repair a body, and therefore it sort of fell by the wayside until I think we started pushing this very extensively. You've always had the problem of trauma in war. And people geared up, surgeons were trained, they fought the wars, they treated the victims, and then during peace, it all fell away again.
Is trauma the same as shock, though? Something you've called a momentary pause in the act of death. What do you mean by that?
Well, all of us are going to die in shock unless we're disintegrated or blown away or something like that. But the last thing that happens to you in the death process is going into shock. And also injury can put you in shock, which if it isn't treated very rapidly, well then you're going to die.
What are the symptoms?
Well, the symptoms are cold, clammy skin, weakness, anxiety, and as you pass further on into the whole process, why you become disoriented, comatose, and that's how you make your exit. It's all secondary to this problem of perfusion of the tissues. What do I mean? It's like irrigating your garden, and then you let the water run down the rows, and the garden is, the plants are irrigated and everything is fine. But once it starts drying up, or you don't get enough water in some rows and others, then certain things happen to your body which are incompatible with survival. And therefore you go into shock and you die.
That's so medical, incompatible with survival. That has to get the euphemism award for this week. You talk also very poetically about something you call the golden hour.
Yes, we have found out, we did tremendous amounts of research in the 50s in animal experimentation and these necessary things because we were developing new pump oxygenators, new valves for the hearts, new blood vessels, all of these things. You couldn't buy them off the shelf like you do now. And in this process, we began looking at the shock problem And we became concerned about what we call hemorrhagic shock. That is shock that's the result of your body losing its blood supply by bleeding, by a torn leg or something like that. And as a result of this, some people would survive and some wouldn't. Some would live a specific length of time and some wouldn't. Some would live longer than others. And as we looked into it, it became a process of identifying two major factors. Number one, the severity of the shock. How much did you bleed out, or how much injury did you have in order to produce the shock, and how severe was the fall in blood pressure? And the second major item was the length of time your body could stand it. Because your body has built already in the system a feedback mechanism where if you don't get the proper things, your body manufactures them very quickly. And your body takes over and tries to keep you alive until the repair process can begin. If it cannot, then certain systems or certain organs in your body are injured or destroyed, and as a result of this, you die. The problem is, how long does it take generally with severe multiple injuries? And we call them multiple systems injuries. What's a system? Your head, your chest, your belly, your legs. So if you've got multiple injuries, how long can you survive without being cared for? And we've found out, both in our animal research and both in working with patients, you have about 1 hour. You have 60 precious minutes to either get into a system which has all of the resources, the doctors, the nurses, the equipment, and all of these things to take care of you, or you're going to probably die.
Before you had the centers you now have, we had, what, 2/3 of our accident patients brought in dead on arrival because it took longer than an hour?
Well, many people come in dead on arrival. One of the major reasons is that the traditional way of bringing patients into the system by ambulance has been surpassed in these kinds of problems by using helicopters. And so the patient who traditionally died on the roadside, the patient who died in the ambulance, now arrives into the system to die because of the speed.
Before I ask you about what happens there at your trauma centers, shock centers, let me ask this, Dr. Cowley. We've had medical practitioners now for ever so many centuries, whether they knew what they were doing or not. And when we had the gladiators who wounded to one another, I'm sure these scientists saw enough dying people to recognize certain things that happened, these similar symptoms. Why have we not paid closer attention to that golden hour and to these services prior to the last 20, 30 years?
I think one of the major reasons is there's been no opportunity for observation and study of somebody in shock. There was a greater opportunity, again, in times of war, when you saw lots of patients who were injured and who were in shock. But then again, these long periods of peace, it's all forgotten, and it all has to be relearned again.
Except our times of peace are such on the highways that it might as well be war. In 1966, the Emergency Highway Act, isn't that what started statewide interest in emergency medicine?
Yes, I was on the National Research Council during that time, and we published a white paper called Accidents, the Neglected Disease of Modern Society. Everybody was ignoring this. Everybody was doing all their other things, but here was a very critical problem involving young kids and young men. And it was a problem where you don't see the things that you see with long-standing disease. For instance, if you have cancer, you're sick generally a long time, and everybody knows you're sick, and everybody sees that you're getting worse, and that type of thing happens. You see the same thing with heart disease, unless they have a sudden calamity, but generally with heart disease they get sick and more sick until finally something happens. But in this field, you can go home tonight after you and I get through talking, and you're perfectly well, and your family is well, and suddenly the family gets a call that you're dying, or that I'm dying, or that your boy, if you've let him borrow the car tonight to go to the dance at 2 o'clock in the morning, he's dying. These are the calamities that are taking place, and most of them are unnecessary.
Because of that golden hour and the treatment that could be provided
If we could provide this kind of treatment everywhere, then there would be a tremendous decrease. For example, in 5 years, we've cut down the mortality rate for these kinds of injuries from 70% down to 20%. And it's simply because we've developed a system of care. And there is no system of care in medicine generally. And this had to be developed to take care of the patients. With cancer, we can't go very much further. I'm a chest surgeon, and I've operated on people with cancer of the lung. I've had them have cobalt therapy. I've had them have radiation of different kinds, chemicals and all these things, but you've gone nearly as far as you can go until somebody really finds out what's causing cancer. And the same thing is with strokes and heart disease and so forth. We bypass blood vessels in the heart, we do all these things, put in valves, you do all these things. But really the major problem is, why do blood vessels get hard? And if you knew that, you could prevent the strokes, you could prevent the kidney problems, the heart problems. So you've got to have major discoveries in these two biggest killers. Now your third biggest killer, you don't have to discover anything. All you've got to do is take all of the things in the community and put them together into a system so that the people get to the right place at the right time and their lives are generally saved.
Okay, now I want to go back to the remarkable poetry. Let's go to a shock trauma center now, and in comes a patient that's just been through a rather traumatic, been through a pretty horrible accident, rushed in. What happens then is something you call controlled chaos. Describe the scene.
Well, what happens generally when you go into an emergency room, you're looked at, a decision is made generally by the least trained physician, until recently, where there are better trained physicians coming in the emergency rooms. But before, he made the decision, he didn't have the ripe clinical judgment, and therefore he's, well, we'll set him aside and we'll go on with this problem because this man's bleeding and looks terrible, and this man doesn't look bad at all. But then when he turns around to treat this man 20 minutes later, he's dead. Or you go up and get your x-rays on another floor, and all of this moving of critically ill people, their bodies can't stand this. And therefore, that's why you bring all of the things in a trauma center to the patient. So when they're admitted into our area, as quick as they're moved off the helicopter, they're very quickly examined. They have intubation if it's necessary. They
What's
have
that mean?
Putting a tube down their windpipe so that they can breathe, immediately stopping the bleeding and getting them into the unit. Now in the unit, there are people that are sitting waiting. They can either operate on this person immediately, or they can resuscitate him, or they can do a number of things. So you have a group of physicians and nurses sitting there waiting to take care of you. And then the controlled chaos is simply they all have the roles. It's no different than you setting up your television program. Everybody has their roles and things to do. Everybody knows them, and everybody has his little job to do. And as a result, you have a better opportunity to survive.
What are the circumstances under which you operate without the kind of diagnosis you wish you had?
Well, traditionally in medicine, the major goal has always been taught the medical student, the physician, and that's what's practiced, is diagnosis before therapy or before treating. And that's traditional. We don't do it that way. If we wait to make the diagnosis, you're dead. So we suspect and we treat the patient immediately, and sometimes we simply open their, cut off the front of their shirts or trousers and operate on them with their clothes on. Sometimes we have to be able to step into the operating room. We will operate long before we have a total diagnosis because we're there to save the life. That's our major goal.
You operate on a hunch? You suspect some internal injury because of some evidence that you wish you could check, but you go right in?
You can't wait. For example, we used to have problems associated with some of our orthopedic colleagues. They wanted to do a total body x-ray. They wanted to do a total nerve assessment. The people that come into our trauma center are dying, and they're not like the typical patient.
What percentages of patients on which you operate didn't need it?
I would say less than 2%.
So your hunches are 98 out of 100. The evidence is that obvious, or your skill is that great?
Well, you're using seasoned physicians. You're seen right there by a seasoned man that's his ball game. That's what he does. You're not being seen by somebody who's called down to take a look at you, who hasn't probably seen something like you have in years, or months, or weeks, so forth. It's no different than heart surgery. When we did heart surgery, when I did heart surgery, why, you had to have a team, but you also had to have enough patients that you kept the team active and rapidly moving and knowing their roles and so forth. And when you didn't, you had difficulty with survival. And that's the same way with this. You can't depend on unseasoned people if you're dying. You need the very best of everything right there and then. And that's what we provide.
Your shock trauma center's manned 24 hours a day?
24 hours a day.
Peopled, staffed?
Total staffed and
ready to go.
Ready to go. Our operating rooms are ready to take care of.
How many patients can you take simultaneously?
Well, we've taken care of high as 9 patients in 2 hours, and these are all these kinds of patients. Before we were able to open up our own operating rooms, we never send our patients over to the general hospital. We have our own operating rooms and so forth. I lost 15 patients in 8 months simply because our operating rooms weren't opened up. They had to go down the corridor from our center half a block, upstairs a half a block, and then wait for the operating room. And waiting for the operating room, they died, which all you had to do is open up that belly and pinch off that blood vessel even with your fingers.
How many patients do you get, or what percentage do you get, who weren't in an accident of the common variety, but were in another hospital, or got into trouble on somebody else's operating table through nobody's fault? Well,
60% of our patients are picked up directly by helicopters and flown in. And the other 40% are inter-hospital transfers. That is, the hospital says, I've got a man who's been operated on. He has developed sepsis or infection, severe, he's in shock. We feel that you can do a better job than we can, and he is transferred out. Or somebody who is very ill, who's had an operation, and now this person, he has got to have another operation, and therefore he's immediately transferred in too. So you're handling patients who have been operated on, patients who have been treated, who have been retransferred because they know that they don't have the resources to manage the problem and send them in, and you have the direct pickups by the helicopters. And the amazing thing about the helicopter system is that only 4% are misdiagnosed. It speaks well for these crews.
These are the paramedics who are diagnosing as they bring them in?
At the scene. And this also speaks the same way for many of the paramedics on the ambulances.
Well, it's funny, in your business then, speed is the critical factor. And I'm sure you've seen so-called emergency waiting rooms in general hospitals. I have waited there, both injured and as the parent of somebody injured, and it's much worse in the latter case. where it may or may not be as bad as you think it is, but you wait 2, 3 hours sometimes. Do we have losses of life in those places?
I don't think so to speak of, that you could really say losses, because those who are dying or come in, there is a patient who comes in and he's waiting and he's found dead. That's true. But I don't think you see much of that. And what I'm trying to say is speed is paramount if you're bleeding or you can't breathe. And speed is paramount if part of your system's got to be put together or that part of the system isn't going to survive. And that's why we've developed other centers. For example, a hand center. All of our patients who have their fingers, hands off and so forth, go to Union Memorial, and they do a tremendous job putting them back on, and they're working, most of them.
I read that some of the hospital physicians aren't all that fond of these trauma centers. Some of them say, well, they can't really do any better than we. Is there that kind of professional jealousy there?
Yes. And I think most of it's misunderstanding. And most of it is protecting turf. For example, when we began, our unit was empty. You couldn't get a patient in because nobody would send one. I can do this just as well as they can do it. And I'm sure they could. You know, we aren't the know-it-alls. It's just we are working in a very specialized field. And with lots of patients, we can manage, I think, better. But what happened was that then we began treating some of the patients, and they began to survive. And so then they started sending more patients, and they were surviving where traditionally they didn't survive. And as a result of all of this, finally we were accepted after years of really battling.
Within the profession?
Within the profession and the hospitals and so forth. And the physician who thought they're going to take all of my patients, are going to do this, are going to do that. Now that patient has a way of handling a dilemma. What is his dilemma? Out in the field, out in the rural areas and so forth. I have this patient who's dying in the hospital, and I have a medical practice. And I've got to choose. If I take care of my medical practice, he's going to die. If I take care of him, I lose my medical practice. Now today, all he has to do is pick up a phone and say, look, I've got a problem, I can't manage it, can you help me? And the chopper's there, or the ambulance is there, and this man is brought in. The physician's taking care of his practice, he's doing what he knows how to do best, all of these things. He knows that the patient's getting the very best treatment, so when the patient's well, it's handed back to him.
I read a recent a short set of articles in the newspaper with those usual paper-selling headlines. Said city trauma system. They were talking about Baltimore City. City trauma system doesn't work, you know, one of those leads. And in it they said some of the ambulance drivers purposely take a shock patient to the nearest hospital rather than the nearest shock trauma unit. Some of the physicians at the shock trauma unit don't trust the information given to them by the paramedics, and a short litany of charges. That must have been very disappointing to somebody who's been in it for as long as you have. What is that all about?
Well, that's part of the growing up process. Since World War II, everybody had a problem getting a physician, and they went to the emergency rooms. And then the ambulances were also going to the emergency rooms like they traditionally did. And so in order to make the system function, if you had an emergency, you went to the nearest hospital. We have become so advanced today that often if you go to the nearest hospital, to speak in the vernacular, you've committed suicide, because that hospital can't manage your problem. And it's better to bypass some hospitals, and there's no reflection on the hospital that's bypassed. To get to a hospital that can manage all of your problems, your chances of survival are better. Now, when you look at 30 or 40 years experience of going to the nearest hospital, and suddenly you step in and say, like we did in the city, look, There are certain hospitals that have the facilities to take care of the severely injured. And it's more sensible to turn around your ambulance or go further and get him to that facility than it is to the nearest hospital. Because number one is the golden hour. If you, for example, are put on an emergency room table in an emergency room, and then you decide to move that patient in the city of Baltimore, the time frame is 3 hours. So you've lost your chance to generally even in a transfer. And so when you have these kinds of problems cropping up, and now you're telling the ambulance crews to take them to the area where they belong according to the protocols they have, why then some of them resent it. Some of them are older people. They've been doing this way. And they're like all of us. We hate to change. And some of them, they are enticed by that hospital to, well, bring them here anyway. We're not a trauma center, but we can do just as good. And this is being evaluated. And then you have the other problem of cost effectiveness. All of the hospitals in the city can't have all of the things that are necessary if you're severely injured to take care of you. And therefore it's sensible to have just a few. For example, we couldn't have about 15 public education broadcasting systems in Baltimore. We have one.
Certainly not, Dr. Cowley.
And so that's how it is with that kind of a thing. Now, our first examination, 3 months of the data, 40% of the patients didn't get to the right place for some reason or other. And that'll be corrected. But also, when we just examined gunshot wounds of the chest and abdomen, your survival chances were twice as good if you went to one of the trauma centers than if you went to one of the other hospitals. And every time we talk about this, we get in lots of trouble because everybody's saying, I'm just as good as you are, and that type of thing. And it isn't that. It's just that certain areas can do better because of the equipment and the experience and the training. And other hospitals, rather than try to compete and spend more money and so forth, they could do a much better job of doing something else. Maybe just treating heart attacks or having a better outpatient department or some of these things.
This is Dr. R Adams Cowley, a pioneer in a new specialty in medicine. Maybe new is the wrong word. Traumatology, emergency medical services, which is somehow on the cutting edge of medical science. A Marylander, known across the world, and somewhat of a missionary when it comes to saving lives. We hope you'll be here next week to see another missionary, perhaps, and we hope you'll be here in person.
In Person will be seen at a new time, Wednesday evening at 7, beginning next week. And remember, a repeat of tonight's program may be seen Sunday afternoon at 4.
In Person is brought to Marylanders through grants by Waverly Press Incorporated, the Williams & Wilkins Company, and the members of the Maryland Center for Public Broadcasting.